surgical options of shoulder instability. If you go to literature and try to identify how many surgeries they are described for recurrent shoulder dislocation, and then the literature says that there are more than 150 surgeries and their various modifications. So altogether, more than 500 methods of treating this recurrent shoulder dislocation is described in literature. So these surgeries broadly can be classified as a bony procedure or a soft tissue procedure. And then there are another classification which is known as a anatomic procedure and the non-anatomic procedure. So as you know that it is not possible to cover all those things in one lecture, but however, it is very important to understand that all that 500 surgeries has become history now, and it is just part of the academics. At this moment, there are only three gold standard surgery, which has been very commonly used for recurrent shoulder dislocation. These are the Bankart repair, Latarjet procedure, and the remplissage. This is the three gold standard procedure we are going to discuss about basic of these procedures. So we all know, and Rohit last time very nicely elaborated what is Bankart lesion. So Bankart lesion is a labral tear of the anteroinferior part of the labrum is torn. You can see in this cut as well. And if you repair this, that is known as the Bankart repair. I'm going to show you a very short animation video of Bankart repair, how it is done. This is the Bankart lesion. You do arthroscopy, then put few anchors. So this is the first anchor that has been deployed. Now first anchor has been deployed, and this anchor will have certain threads. So next step is to pass this thread underneath the labrum. There are various devices. In this case, the suture shuttle is being used. And then you pass this thread underneath the labrum, and then you tie this thread so that you bring this labrum to the glenoid. And you do this usually 3 to 4 times. Most important of this Bankart lesion is this is an anatomic repair of the lesion. So you address the lesion itself. Unlike the Latarjet procedure, in which this is also known as a coracoid transfer, in which you bring some part of the coracoid along with its conjoint tendon and then place into the anterior part of the glenoid so that the glenoid is widened. So this is a coracoid transfer. Let's see the animation of this technique, how it is done. So you go through the deltopectoral approach, and once you open the deltopectoral approach, you'll find out the coracoid. You do osteotomy of the coracoid, remove the undersurface so that this becomes a cancellous part. Make 2 drill holes. There are various jigs are available to do this. Make 2 drill holes. Then you open the subscapularis muscle and then the capsule. So once you open this subscapularis and the capsule, you will reach to the glenoid. You make the glenoid a raw area. There are various retractor. I'm not going to detail of that. Use burr to make the anterior part of the neck raw, and then you place this coracoid piece into the anterior aspect of the neck so that it gives you a better stability. So Latarjet procedure is a very important procedure, and this has the triple effect of Latarjet, which is most commonly asked question to our residents as well. So these 3 effects are it acts as a bone block. So you put a bone block, so it acts as a stopper as well. The second thing is, if you do a true Latarjet, you can use the coracoacromial ligament and do a capsular shift as well. And then the third one is this conjoint tendon, which will act as a sling for the prevention of the dislocation. That is why it acts as a Latarjet procedure, has triple effect. That is why the outcome of the Latarjet procedure is said to be better compared to the other one. The third gold standard is a remplissage. So remplissage literally means It comes from a French language and it literally means to fill in. So what you do, this is done not for the glenoid, but for the Hill-Sachs lesion. So Hill-Sachs lesion is being filled with the infraspinatus tendon. I'll show you my animation of this technique. So what happens if there is a dislocation? The humeral head goes below and the inferior part of the glenoid causes a depression fracture into the posterior superior aspect of the humeral head. So this is the depression fracture which has been called, and just since it is a posterior aspect, there is a supraspinatus. So what you do is you put your anchor into this center of the Hill-Sachs lesion, take out this suture across the infraspinatus and tie it over. And if you see that, if you tie at the end, this gap or this Hill-Sachs lesion or this Hill-Sachs fracture is being filled by the infraspinatus and the capsule. And what it does, it makes the Hill-Sachs lesion extra articular so that this Hill-Sachs lesion doesn't go and engage with the glenoid. This is the basic principle of the remplissage. So if we compare between the Bankart and the Latarjet procedure, which is basically at this moment the gold standard for the treatment of the recurrent shoulder dislocation. So we all know that the advantage of Bankart repair is arthroscopic. This can be done by arthroscopic technique. Although some people still do a Bankart repair by open technique, but the gold standard at this moment is the arthroscopic Bankart repair. It is minimally invasive. And I told that this is an anatomical procedure. So you repair the Bankart lesion. Whereas if it is a Latarjet, usually it is an open surgery. Excuse me. Some people still do arthroscopic Latarjet. We have not able to do that in our center. But by and large, Latarjet procedure is an open procedure. It is more invasive because this is a formal open procedure and you have to do a osteotomy. You transfer the thing from one place to another place. That is why it is non-anatomic procedure, which is not very readily accepted by many people. But if you see this recurrence rate of Bankart repair, it is up to 14% by the various literature. But if you compare with the recurrence rate of Latarjet, it is only 4%. So the recurrence rate after the Latarjet procedure is only 4% compared to the 14% of the recurrence rate in arthroscopic Bankart repair. This seems that the concept is tilted more towards the Latarjet procedure. But if you consider the complication of Bankart repair is always less severe complication and the minor complication, whereas the complication of Latarjet procedure is very, very severe. And that is why many people fear of doing Latarjet procedure as a primary procedure. So most of the places, this Latarjet procedure are done if there is a failure of the arthroscopic Bankart repair. So considering these two options, the Bankart and the Latarjet, which one is better? There are divided opinion. So basically the French group of people, if you see, they do Latarjet procedure for most of their dislocation of the shoulder, whereas American group of people and the American allies, they do a Bankart repair for the most of the recurrent dislocation. Which way is a right way? Probably both ways are right way if you are trained. If you are trained by the American people, probably you do a Bankart repair primarily. If you are trained from the French people, probably you go ahead with the Latarjet procedure. But the most important thing to decide either to do a Latarjet procedure or the Bankart procedure is look at the recurrence rate. So choice of the treatment depends upon the estimation of the recurrence rate. If you presume that the recurrence rate is going to be very, very high, probably you have to change the method of the fixation. So how to decide which patient will have higher recurrence rate? And to decide this, there are so many various options. So one of them, Dr. Rohit last time spoke about ISIS. So this is a instability severity index score. I'll talk about this in little detail in my subsequent slide. There are the bone loss, which is again considered as a main and the most important one. I have few slides about the bone loss as well. Some people talk about Easy Itoy and the Giovanni group. They talked about the glenoid tract to decide either remplissage has to be done or not. And then, engaging or non-engaging Hill-Sachs lesion for treatment of the Hill-Sachs lesion. These are again the controversial one. Level of activity. Some people say that probably the level of activity has to be the main factor to decide either to go ahead with the Bankart repair or to decide to go ahead with the Latarjet procedure. So to summarize, there are so many factors that has to be considered before taking a decision regarding the Bankart or the Latarjet procedure. So this is the ISIS, which is published in 2007 and has set a trend mark. And essentially, this is from the French group of people, the Pascal Bolley and the Blag. They have given this ISIS score that Rohit last time very elaborated. I'm not going into detail of that. But what they say that if this score is less than 7, probably a Bankart is a right choice to do. If it is more than 7, then Latarjet procedure has to be done. This is about the glenoid defect, which has been, propagated by Giovanni Easy Itoy and the Steve Burkhardt, my teacher himself. So what they say that if there is more than 25% bone loss, then you have to do a Latarjet procedure. If there is a less than 25% bone loss, you have to do a Bankart procedure. So basically, at this moment, many people in the many part of the world, people use this either ASIS, ISIS, guideline for decision making, either to do a Bankart repair or Latarjet procedure. Or in American continent and the American influenced countries, they use this 25% and the on track, off track concept to decide either to do a Bankart or to do a Latarjet procedure. So many places, this 20 to 25% was considered as a critical bone loss, and people used to think that if any bone loss which is more than 25%, it has to be Latarjet. Less than 25%, you can do a Bankart repair. But in subsequent literature, subsequent studies, in the meta-analysis, they found that the outcomes are poor even if there is a bone loss of about 13.5%. So they named it as a subcritical bone loss. So what to do when there is a subcritical bone loss? So we have a clear concept that if there is a more than 25 or 20% bone loss, probably a Latarjet procedure has to be done. But what about a bone loss which is between 13.5 to 20%? And this is the gray area at this moment. And this is the group of people that we have to decide. So how to decide about this subcritical bone loss? So we have been following this protocol. So we decide our patient into three groups. These are low demand group and the high demand group. And those people who do not fall into low and high demand group, they are considered as a middle group. So we divide our patients into three groups. So we all know that high demand groups are the basically the sports persons, laborers, and those people who require frequent overhead activities. Low demands are like us, doctors, housewives, those people who do not use their shoulder for overhead activities. And then a good bunch of people, they fall into the middle group, who are basically the recreational sports persons and this kind of people, who do a little bit of sporting activities, weekend warriors. These are the people who fall into the middle group. So for all low demand patients with the subcritical bone loss between 20 to 13.5%, we suggest a Bankart repair. For high demand patient, even if he has a 13% of bone loss, we suggest a Latarjet procedure. Now the question arises, what to do with the middle group? In this group of people, we have to measure the bone loss. So if it is less than 20% bone loss, probably a Bankart procedure is a good choice for that particular patient. If more than 20%, then a Latarjet procedure has to be done. The second thing is how to deal with the Hill-Sachs lesion. Rohit very clearly, demonstrated last time. If the Hill-Sachs lesion is on track, we can leave it alone. If the Hill-Sachs lesion is off track, then we have to do a remplissage, as I showed in my animation. There is another dilemma amongst our fellows and colleagues that which investigation is appropriate for a patient with a recurrent dislocation. So we all know that X-ray is very, very essential, but most of the time a patient with recurrent dislocation, they do not present like this, The shoulder is very well reduced and there are very few things you can see in the X-ray. That is why probably a CT scan or MRI is very, very essential. So in our part of the world where economics makes a difference in choosing what type of investigation to send, so if for that also we again make our decision either to do a CT scan or MRI based upon the same protocol. So if a patient is low demand, so we are going to do a Bankart repair. So Bankart repair is a soft tissue procedure. So we need to see the status of the soft tissue. That is why we do an MRI. Even a patient is of high demand, so we are going to do a bony procedure, which is a Latarjet procedure. So we need to see what are the soft tissue status so that you identify either the soft tissue has to be addressed at the same time or not. So in that case also you do a Latarjet. When you are a high demand patient or planning a Latarjet, probably MRI is a choice of investigation. Now in the middle group is the group where you have to exactly measure the bone loss so that you decide either you do a Bankart or you do a Latarjet. In that case, probably CT scan as well as the MRI scan, which is both is essential in this group of patient. But if you are asked which investigation you are going to do, whenever possible, we have to advise both CT scan and MRI for a thorough evaluation of the soft tissue as well as the bony component or the bony component of the stability of the shoulder. As far as the CT scan is concerned, we don't need a small cuts of the CT scan. These are the four pictures that we need. This is of the both the sides, the affected and the normal side, and this is known as the en-face view. So end-on view of the glenoid, that is what is required. And to measure the bone loss, you need to have both the shoulder en-face view of the glenoid. And the second you need is a posterior aspect of the humeral head. If you see that, this is the posterior one is of normal side, the other one is of the pathological side, so that you can see the Hill-Sachs lesion and you can measure to identify either it is a on track or the off track. So this is the only picture that you need to make a decision either to go ahead with the Bankart repair or the remplissage. So whenever you advise a CT scan, you have to write a shoulder protocol so that our radiologists, they do a shoulder protocol, which is basically these four films which are very, very essential. Now after general concept of either to do a Bankart, Latarjet or remplissage, let us talk about some special situations, especially the first time dislocation, shoulder dislocation in elderly, shoulder dislocation in special cases like epilepsy, generalized ligamentous laxity, and the voluntary dislocation, along with the neglected dislocation. I'll come to this one by one in very brief slide. I'll try to little bit elaborate in the first time dislocation because this is a very current trend and there are a lot of literature, meta-analysis and the review article coming in this aspect, what to do in case of first time dislocation. So I'd like to bring to your notice few facts. The number one fact is if a shoulder dislocation, first dislocation has occurred in a patient of less than 20 years, there is a possibility of recurrence in 90%. So if a patient of 19-year-old comes to us with first time dislocation, that patient will have a 90% chance of recurrence. So we have to think in that line. So whereas if you see someone who is above 40, the recurrence rate is just 10%. So the younger the patient, higher the recurrence rate. This is the fact that we know from almost 70 years ago. Another thing is the type of sporting activities and the demand of the patient. So if you see that the recurrence rate after first dislocation, traumatic dislocation in general population are considered as a 2%. But in sports activities, if it is 8% in recurrence in ice hockey, and the recurrence rate is 76% in contact sports. So this paper says that, again, pretty old paper, but this paper suggests that high demand patients have higher recurrence rate after conservative management. So probably indicating towards a surgical intervention. The third fact, there are so many people who are comparing the cost benefit analysis And this paper, which comes from 2015 by Chapus, he says that acute repair is recommended and this is cost effective. So this is a 25 years follow-up cases of all the primary dislocation, and they have tried to identify the cost benefit of treating after the first dislocation surgically and treating conservatively after the first dislocation. So cost benefit also is there. As far as the outcome is concerned, I'll not go into detail of this, but if you see the recent literature, 2017, 2018, 2019, and there is a meta-analysis even in 2020, which says that a young athletic patient with first shoulder dislocation has to be treated conservatively, and this has a better outcome. So if you go to literature, the very high impact journals like AJSM, International Orthopedics, and the OJSM, they say that early repair is recommended in young and active patients. So if there is a young and active patient, probably we have to at least suggest that patient. So this is just a case scenario in which a 19-year military recruit fall while monkey crawling. He had a first dislocation. So in this part, this type of patient who is a very high demand, he's a recruit, he has to go back to his training. Probably operative treatment seems to be beneficial in this group of people. And same thing applies to a very elite sportsman as well. The second important point is a dislocation in elderly. If you see this article which says that in elderly patient of 40 to 60 years age, there is a 38% associated rotator cuff injury. If it is 60, more than 60 years of patient sustains anterior dislocation, there is a 80% chance of rotator cuff injury. So whenever we get this kind of patient, we always have to look at the rotator cuff. This is very interesting case. We treated at B&B hospital itself. So she was about 64-year lady, a first time dislocation of her shoulder following fall. It was very well reduced and she was sent back, but she never improved. And when she was referred to us after 4-5 months, since she was not able to abduct her shoulder, we did a MRI and you can see that there was a rotator cuff tear of this particular patient with parte grade 2 retraction of this tendon. So we did a rotator cuff repair of that particular patient and she did very, very well. So whenever we get an elderly patient, especially who is above 40 years, we must think about rotator cuff. So unless we exclude the rotator cuff tear, we should not dispose our patient just by saying that we have reduced his or her shoulder into place. Another important dislocation is dislocation in epilepsy, which is very common. We know that during the epilepsy, there is a violent contraction of the muscles, which may lead to various types of dislocation. And usually in epilepsy, you will find out a posterior dislocation, neglected and unreduced dislocation, which is very, very common. And even you'll get a fracture dislocation in case of epilepsy. So the treatment as far as with the shoulder dislocation is basically the medical treatment. And it says that the literature says that at least 6-month seizure-free period and good control of the seizure with appropriate drug has to be there before you plan for a surgery. And the treatment of anti-epileptic drug must be continued at least for 1 more year after the surgery, even if the patient doesn't have a seizure. So this is the prerequisite, and the surgery described or recommended for these epileptic patients are basically the Latarjet procedure. But recent advances of understanding of this epilepsy and the mechanism of dislocation, people have identified that this conjoint tendon also violently contracts, even if it is transposed or the transferred to the glenoid. So nowadays, Latarjet is not the gold standard for the surgical treatment. There is a newer technique which is known as the Eden hibernate procedure, and this Eden hibernate procedure is the grafting by the iliac crest graft. The anterior glenoid bone loss is being replaced by the iliac crest graft, which doesn't have any muscular attachment. So in case of coracoid transfer, there is a muscular attachment, and again these contraction of that muscle may lead to the rip apart the coracoid process from the glenoid. That is why this is a Eden hibernate procedure. not very much done in our part of the world, but we were able to do in two of our epileptic cases in which we did the Eden hibernate procedure, and both the patients are doing very, very well. The another important subgroup of dislocation are dislocation in the generalized ligamentous laxity. So whenever we get a patient of shoulder dislocation, we must classify them according to the generalized ligamental laxity Beaton score. Again, this Beaton score has been described by Dr. Rohit in his last talk, so I'll not go into that detail. But when we talk about general dislocation in generalized ligamentous laxity, these dislocations are usually multi-directional. So we have to very actively search for what are the areas through which the shoulder can dislocate. If you repair only one anterior part, there is a possibility that the shoulder will dislocate posteriorly. That is why it is very, very essential. And for this kind of generalized ligamentous laxity, the mainstay of treatment still remains the rehabilitation. So try to rehabilitate these group of patients. Rarely surgery is required if the patient is very, very symptomatic and the patient understands the drawback. There is a new surgery which is known as the pan-capsular plication. You can see that these diagram shows that whole the capsule, right? 360 capsule has been plicated and the rotator interval has to be closed. And this again has a high failure rate. So you have to counsel your patient very, very appropriately. And the mainstay of treatment of multidirectional instability is usually the conservative treatment. Something to talk about, dislocation in children. So usually the dislocation in children are commonly the voluntary dislocation. This is an example of a lady whom we treated about 4 years ago, and she had a dislocation since her childhood, and she was able to dislocate her shoulder voluntarily. If you can see that, she was able to dislocate her shoulder. So she was not having any problem, but recently she started having pain of her shoulder, and she decided she wanted to go ahead with the surgery. We did a surgery. Unfortunately, her shoulder again, started dislocating and it failed. So voluntary dislocation is a group where probably the mainstay of treatment still remain rehabilitation and no surgery has to be advised. There is a very, very high, unacceptably high recurrence rate of the shoulder dislocation if you operate on voluntary dislocation. Also, the voluntary dislocation is usually a multidirectional. So my final subtype of dislocation is neglected shoulder dislocation. This type of shoulder dislocation is very common in our part of the world. And if you see the terms used to describe the neglected shoulder dislocations are very, it is called as a chronic, unrecognized, missed, and there are so many, mnemonics. And there are so many definitions when you say it is a neglected or chronic. Some article say the 1 week, and there are various paper which ranges between 1 week to 12 weeks. So there are no definitive consensus on when to say it is a neglected shoulder dislocation. But most of the time for our part of the world, the Indian paper, they say that if the dislocation is more than 6 weeks, probably you have to consider it as a neglected shoulder dislocation. So the treatment of neglected shoulder dislocation is close reduction is very, very difficult after 2 weeks. And some literature, they suggest that you can try up to 6 weeks, but they suggest if it is especially an elderly patient or if it is associated with epilepsy, then probably we should not try a close reduction after 6 weeks. So we should always go for a open reduction. So the treatment available for neglected shoulder dislocation is supervised neglect. Many of us, we don't know that these neglected dislocation, they have good functional range of motion. They have adapted to their disability. So we must always think about what are the disabilities, and that can that disability be corrected by a surgical method. Open reduction and various fixation technique is once popular, and this picture of our own case, which we did about 4 years ago, and the literature says that probably this type of open reduction and fixation through the joint should be always avoided, because this is going to cause a fibrous ankylosis. It is going to damage the shoulder. That is why any pins, any wires that goes through the joint should be avoided. So this is not recommended at this moment. At this moment, basically these are a Latarjet procedure, which is recommended for anterior dislocation, and McLaughlin's procedure, which is described for the posterior dislocation. So this is one of our case. We did about 6-7 months back. He presented to us after 3 months of unreduced shoulder dislocation. 3 times it was tried, and then he was advised for open reduction and internal fixation. Since this patient, this patient was known to some of us, our colleague doctor. He was referred to us. So if you see that the MRI, the shoulder, it was already dislocated. If you see the MRI, there is a Hill-Sachs lesion, and it remained dislocated. We did a open reduction and the Latarjet procedure of this patient. You can see that in the subsequent follow-up, this is the Latarjet procedure. It was a formal open procedure. It was a little bigger incision because it remained dislocated, and this is what the patient has after 3 months of follow-up. He has almost full range of motion after this procedure. So to conclude my presentation, I would again like to reiterate that there are more than 150 surgeries and their modification, which will make about more than 500 surgery described in literature. But the time tested and the provens are only three. So these are Bankart repair, Latarjet procedure, and the remplissage for the Hill-Sachs lesion. Although at this moment, there are only three procedures described, but there are a lot of controversies and challenges to decide which is going to suit to a patient. So that requires an individualized approach to the patient and the individualized approach to the shoulder dislocation that will give us a good idea about which surgery is going to be suitable. At this moment in Nepal, we are doing what we are trained to. There are people who are trained for arthroscopic repair, and there are people who are trained only for Latarjet procedure. So these people are doing only those things. Probably we need to know all these three procedures in our armamentarium so that we can give a comprehensive treatment for a shoulder dislocation. Thank you very much. Thank you very much for patient listening. If there are any question, I'll be very happy to answer your question.